Welcome to Heartbeats from Lifelong Learning, our deep dive series on intracerebral hemorrhage, or ICH. Today, we are taking a close look at the evolution of ICH care, focusing on minimally invasive surgery, or MIS, and the landmark trials that are reshaping how we treat this devastating form of stroke. Our goal is to dissect the data, compare the outcomes, and understand how these new approaches stack up against traditional medical and surgical management. By the end of our conversation, we hope you'll be better able to evaluate the results of these pivotal trials and apply them to your own clinical decision-making. I'm your host, Harita Buva, and I'm thrilled to be joined by three leading investigators in this field. With us today are Dr. Dan Handley, Dr. Jonathan Ratcliffe, and Dr. Ryan Kellogg. I'm a neurointerventionalist in the Dallas-Fort Worth area and also a neurocritical care specialist.
Hi, I'm Dan Handley. I'm from Johns Hopkins Medical Institutions, and I've been working in ICH for the last 25 years.
I'm Jonathan Ratcliffe. I'm a emergency physician and neurointensivist at Emory University Grady Memorial Hospital, and was the co-PI for ENRICH, the current PI for REACH, and have been working on ICH since about 2015, 2014.
I'm Ryan Kellogg. I'm a cerebrovascular neurosurgeon at University of Virginia, and I predominantly treat patients with ischemic and hemorrhagic stroke, and have been involved with various ICH evacuation procedures since 2020.
Fantastic. Let's dive right in. The world of ICH treatment has been energized by three major trials, MISTIE III, ENRICH, and MIND. To set the stage for our audience, I'd love to get a concise overview of each. Dan, could you start us off? Give us the 30,000-foot view of the MISTIE III technique and its top-line results.
Sure. MISTIE was a phase 3 500-subject trial comparing MIS 1-to-1 with medical treatment. It was built on MISTIE II, a phase 2 100-patient trial doing the same thing. Together, they strongly suggest that clot size reduction with minimally invasive surgical technique is a key component for a primary surgical treatment of supratentorial ICH. MISTIE itself is a catheter and cannula-based removal of ICH with, after cannula removal, TPA irrigation to optimize the clot removal. We now use real-time observation of cannula placement and subsequent catheter placement with CINE-CT to do the procedure. The main findings of MISTIE III were 4% of the patients in the intention to treat analysis had an improvement in the percentage of patients. It was 4% in the 0 to 3 MRS category versus the 4 to 6, and 10.5% in the per protocol analysis, with a number needed to treat for ITT of 25 and a number needed to treat of 10 patients to get one improvement in the per protocol. The estimate of an apparent 10% benefit from MISTIE II, where we found such a benefit, wasn't reproduced in MISTIE III due to inconsistent application of the surgical removal task. Consequences were significant for future trials, and I hope eventually to the day-to-day use of minimally invasive surgery to reduce clot size and improve function. We're here today because other clinicians believed in that promise of MISTIE III and have tested the equipoise for initial surgical management versus initial medical management. And they've performed two more trials. Jonathan ENRICH and Ryan has been a part of MIND. And those trials are more the same than they are different. The 30-day and 1-year mortality are decreased by MIS and MISTIE, with point estimates of the same effect in ENRICH and MIND. Similarly, a policy of surgical removal, acute intervention for clot size reduction in MISTIE, ENRICH, and MIND led to the same significant finding of fewer serious adverse events in the surgery group versus the medical group, which is an unusual finding in any clinical trial. A policy of this policy extends to both the surgical removal of deep and lobar. I'd like to show one slide about how consistent these findings are. As you can see, this dense slide is simplified by showing the demographics of the patients and the intervention in the top section, outcome by location, and the benefit by location in the bottom section. And what you see is MISTIE and MIND enrolled 60% deep and 30% lobar. And ENRICH, because it was enriched with lobar in an adaptive design, had the reverse. It had 70% lobar and 30% deep. The surgical task was performed well in all three, with MIND having the smallest median end of treatment volume of 6 mLs. And the starting hematoma size is essentially in the 40s or 50s for all three trials. And the primary outcomes are, as we know, positive for all sites in ENRICH, but dominated, if you go to the bottom part of this slide, by the green area, the utility-weighted modified Rankin for lobar, with signs of concern for the deep using both the utility-weighted and the percent of MRS patients that did not benefit. But the trends are the same across all three trials. And that's my overview, Parnita.
Thank you, Dan. Jonathan, would you describe the technique studied in ENRICH, please?
Yeah, thank you. Happy to be here today, Brita. So this is going to be fun. The ENRICH trial, which was the early minimally invasive removal of intracerebral hemorrhage trial, in that study, we evaluated the minimally invasive transsulcal parafascicular surgery, or MIPS, for evacuation of our supratentorial intracerebral hemorrhage. We were using the brain path port and the Myriad devices, and surgeons were accessing the hematoma through a small craniotomy using a natural sulcus. And this enabled the surgeons to have a bimanual clot evacuation under direct visualization. Further details of this can be learned about in a related podcast to this group. ENRICH was the first clinical trial, though, to demonstrate the benefit of hematoma evacuation. For lobar ICH that was evacuated within 24 hours, MIPS was associated with significantly better functional outcomes at 180 days, the primary outcome, based on a utility-weighted MRS overall difference of 0.084 and about 0.127 in the lobar group. And that was using the utility-weighted when it was as a 0 to 1 scale. And so we reduced the 30-day mortality as well in half at 9.3% versus 18% in the medical management group. The functional benefit was not seen in the deep or anterior basal ganglia hemorrhages, and enrollment after 175 patients, we did ENRICH, and we focused exclusively on the lobar hemorrhages going forward. Those deep hemorrhages, the posterior probability of effectiveness was about 50%, and the trial was designed to fail early, if you will, because we knew we had a limited sample size in which we could work based on our budget. And so we had designed into the trial early stopping points so that we would not go down a pathway that was not effective, at least in a marked way, which leaves us the door open to further research in this group.
Excellent. Ryan, could you please explain the MIND technique to us?
Sure, Frida. Yeah, so the MIND technique is very similar to the other recent ICH evacuation minimally invasive procedures. The goal is to minimize collateral damage to brain tissue while achieving an adequate ICH evacuation. There are similarities and differences between the MIND technique and those used in MISTIE and ENRICH. One of the major similarities is the use of frameless stereotactic navigation or image-guided surgery. This is utilized to plan a trajectory to place the instruments within the hematoma cavity, ideally traversing the long axis, as is done in the MISTIE study. This technique uses a peel-away sheath. So a sheath is initially placed into the clot under image guidance. And through this 19 French sheath, you generate a corridor to insert an endoscope. The incision for this is rather small, roughly around 3 centimeters, with a 1.5 centimeter burr hole or craniectomy. One of the major differences between this technique and that used in the ENRICH trial is the MIPS technique is a port base that uses a microscope, whereas the technique used in MIND uses a rigid endoscope. This is typically about a 6 millimeter scope that's got 3 channels. 2 of them are used for suction and irrigation, and the third, the center channel, is the working channel that's about 3 millimeters in diameter and is large enough to accommodate the Artemis device. The Artemis device is a wand-based catheter type device that has a side cutting port that allows for morselization of hematoma that's more fibrous and evacuation using aspiration. The general approach for this is also similar, where the port is usually placed into the distalmost portion of the cavity. And once this sheath or port is placed this deep, the surgeon operates by evacuating the most deep hematoma, and gradually, as the hematoma is removed, the sheath and endoscope are slowly retracted back to evacuate the more superficial portions of the hematoma. This is done in a stepwise fashion such that the hematoma is allowed to basically fall into the center of the field of view. And through a combination of suction and irrigation, the clot is gradually removed. Additionally, this technique does allow for identification of either arterial venous bleeders that can be treated with either electrocautery or some form of hemostasis. Ideally, at the end of the procedure, once the entire cavity has been evacuated, a CT scan can be performed intra-op. If that looks like there's significant residual hematoma, this new imaging data set can be pushed to the image-guided system, and a secondary pass for the hematoma can be evacuated. So it allows for more active clot evacuation, unlike the MISTIE technique, but also allows for a very kind of small corridor to operate through.
Thank you all. Now that we have a clear picture of these 3 distinct minimally invasive strategies, let's get into the details. A critical question for any trial is generalizability. Dan, starting with MISTIE III, what were the key inclusion and exclusion criteria? What conclusions are we able to draw about the population most likely to benefit from evacuation? And what other data do you think we need?
Sure. So let me go to the end first and then go backwards, because that's a series of questions. I don't think we've achieved generalizable selection criteria. And I think if you look at the table that I showed you, which is adapted from Keep It Simple, a published version of the same arguments, I think we need more information about location, timing, and technique. MISTIE enrolled ICHs as they come in, which is 3 or 4 to 1 deep to lobar. Deep is far and away the most important site. In MISTIE, the point estimate was of benefit, and when we moved to the per protocol results, which is what I showed in the slide, there's clear benefit, hypothesis generating, but clear benefit at both locations. And the benefit's actually bigger in the per protocol in lobar than it is even in ENRICH. That's what we saw. And we enrolled people who were greater than 30 milliliters, which is one difference between the 3 studies. MIND took people down to 20, and ENRICH used the 30. I don't think we know what the right size limit is for these groups. MISTIE was protocol driven, and we tried very hard, but it's one of my failures. We didn't adhere to the protocol as well as we should have. We had 58% protocol adherence. And if you go back to the table I showed you, it was much higher in ENRICH and even higher yet in MIND. They're both in the 70s, with MIND approaching almost 80% protocol adherence for a major removal. And I think that's what we know. A major removal appears to be beneficial if we look at mortality. I believe that ENRICH and MIND support the goal that, independent of how you do the task, making the hematoma much smaller is good for the patient. And I believe the most recent and thorough evaluation of selection criteria from the Cochrane Consortium, which suggests we don't have enough information about time, technique, or location, and the quality of our information, except for uh, these three trials, is not high. So the heterogeneity is what's high. And that's my feeling on selection criteria. I think we need more data from trials that are high quality.
Thank you. Jonathan?
Yeah, thank you. I think on this point, and many others, Dan and I typically we agree on this, is that more data is required to figure out how to generalize these data and that we're finding in clinical trials, and really kind of target who can perform the best. ENRICH was a phase 3 clinical trial. It was randomized, and we were designed to adapt to the study population based on the location of the intracerebral hemorrhage. So, which included adults aged 18 to 80, so a pretty wide range of age, with lobar and what we coined as anterior basal ganglia, ICH. And really what we were trying to say when we used that term was we really wanted to exclude the thalamus explicitly, and that any posterior structures. The volumes that we were targeting were 30 to 80 mLs, and we wanted everyone to have a Glasgow Coma scale in the 5 to 14 range. They had to have some effect, and also an NIH stroke scale that was greater than 5. We did require that patients had a premorbid MRS of 0 to 1, and this is just to make sure that people were as healthy as possible coming into their event, so that any differences in MRS weren't limited by premorbid conditions. We also wanted people randomized within 24 hours of their last known well, with an expectation of an ability to cross the threshold of the OR within 24 hours of their last known well. And so this was, at the time, this was at the time of the design of ENRICH, this was actually an issue that had to be pushed significantly. But since that time, I think it's become more accepted that the early evacuation is both possible using this technique and perhaps even superior, though I think that the question of time remains an outstanding question. And our colleagues in the MINUTE trial are hopefully going to address that. All of our patients had a CTA performed on arrival to help determine eligibility and excluding vascular etiology of the hemorrhage. We wanted to make sure there was no AVMs or aneurysmal ruptures that were included. We did have patients that had spot signs, and these patients were actually included in the trial. And my neurosurgical partner, Dr. Gustavo Padilla, always enjoyed these cases, as he felt like he had a target for hemostasis. As we know that the spot sign is a significant risk factor for hemorrhage extension. So the ENRICH data did suggest that lobar hemorrhages within that volume target of 30 to 80 and that age target of 18 to 80 were most likely to benefit from the MIPS trial, or from the MIPS procedure rather. Substratifying these data to determine if any subgroups perform better or worse, while clearly articulating the surgical targets, residual volume in this case, for optimal outcomes, I think remains an important point for us to learn. So what is the timing? What is the optimal residual volume based on the location? I think that's one of the key points that ENRICH taught us, is that lobar behaves differently, very clearly, than the deeper hemorrhages. And how does that change the way the trials need to be designed? An early subgroup analysis from ENRICH suggests that these large hemorrhages do not do as well in the deep hemorrhages compared to lobar hemorrhages. End of treatment volume for this cohort of deep hemorrhages appears to be around 6 mLs, whereas evacuation percentages were about 90%, and that seems to be threshold effects for improved function on those deep hemorrhages. Thanks to funding from the Marcus Foundation, our team has designed and began to recruit in the ENRICH clinical trial to better evaluate the effectiveness of MIPS in this deep anterior basal ganglia cohort. So we're excited to see how that progresses.
Great. Ryan?
Yeah, I think overall, if you look at the MIND versus ENRICH, there's a lot of similarities. So looking at the inclusion criteria, it was similar supratutorial ICHs with patients age ranged 18 to 80, and they had to have a NIH stroke scale of greater than or equal to 6, so some kind of neurologic deficit and a GCS of 5 to 15, with a hematoma volume between 20 to 80 cc's. Both deep and lobar bleeds were included. What was kind of different in this circumstance is that time to MIS clot evacuation had to be within 72 hours or achievable within 72 hours. And similarly, they had to have a pre-morbid MRS of 0 to 1, and symptom onset had to be within 24 hours of the initial imaging demonstrating the hemorrhage. The initial protocol did mandate a stability scan within 6 hours of the initial imaging, but this was later relaxed or removed in a later protocol. Additionally, protocol revisions further throughout the study also then excluded patients with severe active infection, kidney failure, or those that were receiving direct 10A inhibitors, and then also those with primarily thalamic ICH. The other key exclusion criteria were similar to the ENRICH study. Underlying vascular lesions such as an AVM, aneurysm, or cavernoma were excluded. Hemorrhagic conversion of an ischemic stroke, significant IVH. Midbrain extension was also an exclusion criteria. And then patients that required absolute necessary for long-term anticoagulation, antiplatelet medications. And then finally, patients that required an emergent decompression were also excluded. Then what's unique to this that wasn't present, I guess, with the ENRICH studies, that expanding hematomas were also not allowed to be enrolled.
Yeah, this really highlights the need to understand the interaction between location, technique, and timing. Surgical trials face the challenge of standardizing a technical procedure, as we kind of alluded to. And we've also talked about the procedure studied in each of these trials. I wonder, how did each of these three studies deal with the issue of intersurgeon variability to ensure the intervention was performed consistently? Jonathan, let's start with you on this one.
It's a great question. This is a question that kept me up at night for a few years. So I'm glad you're asking it. We were really very concerned that surgical variability could actually impact the study to a significant effect, and have a significant impact. But we also felt that we wanted to have a clinical trial that was able to be uh, adopted into practice, and would be demonstrated effective by an individual surgeon that was doing the procedure without direct oversight from the research team. And so um, we felt that surgical variability could be considered from both the individual surgeon level, but also from the perspective of the study site as well. So we required standardized surgical training of the surgeons. That our sponsor at the time was NICO. They provided independent of the clinical trial, and adherence to a detailed surgical manual and video review of cases. The ENRICH study leadership monitored video for protocol adherence and surgical performance, and we were trying to ensure consistency across all centers. So the first two cases of every patient that was enrolled at every center, we watched the video of the procedure, gave the surgeons feedback, but we did not require that the surgeons talk to us or communicated surgical trajectories or surgical planning prior to enrollment. Left that to the devices of the surgeon. Now we were available to discuss it. Our team was available to discuss it, should that be a question that the site had, but otherwise we left it to them. But we also wanted each site to have experience with the MIPS in a preoperative, intraoperative, and postoperative care. So before patients could be enrolled at a center, each site had at least 10 MIPS cases prior to their first ENRICH enrollment. And this did a couple things. It just gave everyone kind of expectations of what they see, how best to prepare, and some of the nuances that happen as you're taking care of a MIPS case.
Yeah, makes sense. Dan?
I'll point out that we did a very similar program with pre-screening, having done the procedure, and then following the first several. I'll point out that Jonathan made a very important statement. Jonathan and I aren't surgeons, and I've always failed when I've tried to tell a surgeon what operation to do and how to do it. You have to have the surgeon have the degrees of freedom to behave as a surgeon when they're doing the task. And the nice thing about all three trials is people seem to agree on the MISTIE idea that we have to make things smaller. And for us and actually it's not post hoc, it's planned analysis. 15 was a very good threshold for all sites. For us, 9 was a threshold for deep and 28 for lobar. Uh, but we did it the same way. Unfortunately, we're the only group that's published the influence of how you do the task on the outcome. And there's a very nice paper by Assam Awad, which I'd recognize to everybody. I look forward, and I'm sure that Jonathan and Ryan are going to show their data. What appears to be the message from our evaluation of MISTIE is it's the task and the adherence to the task that's really important. And that's my read of the uh, higher ability of ENRICH and MIND. 70 to 80% of the time, the surgeon was able to accomplish the task. What we found in MISTIE was that because it was the first ever, people were hesitant and they worried about taking out too much blood might cause a problem and restart bleeding or have other implications for tissue injury. And it sure looks like that's not the case. Ryan?
Yeah, I think what's interesting about the MIND study is they actually did not have quite strict requirements for surgeon experience. They did have a standardized technique which required the procedure to be performed under general anesthesia with the standardized equipment as I described earlier. And trajectory planning rules were specified by the protocol. I would say, again, similar to how MISTIE III tried to generally advise the approach for clot evacuation. But overall, the actual technical component performing the procedure was not, again, influenced by prior experience, which I think is important because for any of these studies, you want to demonstrate that the techniques, if they are to show good outcome, this can be democratized or applied across the board and isn't just relegated to high volume centers. But overall, without these strict prior experience criteria, they did show that on average, approximately 80% treated patients had a residual ICH volume under 15 cc's. And overall, on average, about 80% of the ICH volume was evacuated for a given patient. So I think the study demonstrated that the technique can be applied with good radiographic or volume outcomes.
Yeah, that's fascinating, the differences amongst the three as far as this matter goes. Let's pivot to safety, which is paramount. Ryan, in the MIND trial, what were the most common or serious adverse events you tracked, like rebleeding or infection? And how did those risks compare to what we might expect from standard medical care or a salvage craniotomy, craniectomy? Were there any perioperative strategies most effective in mitigating these risks?
Well, interestingly, they didn't report high rate of infection or rebleed or really any complications secondary to wound healing. They did state that the significant adverse events were less frequent in the surgical arm, as we've seen in other ICH studies. And this was further expanded upon in the summary portion of the paper. But overall, there wasn't an issue with surgical complications. They did mention, though, that there was significant procedural hemorrhage requiring cauterization in 6% of patients. I wouldn't personally necessarily consider this a complication, as it's not infrequent to encounter the bleed source during the procedure. So to me, this is somewhat expected. And they only had to convert to a craniotomy in 1.5% of the procedures. So I look at this as overall, as the other studies have shown, that this is a safe surgical technique.
Similarly to the MIND trial, I think that we saw that the most common serious adverse event as it related to the intervention directly was rebleeding, but we only saw that in 3.3% of patients, and with rates that were comparable or to or lower than the standard care group. The perioperative strategy requires adherence to modern guideline-based ICH management, including blood pressure control, careful intraoperative hemostasis, and the way that the MIPS surgery works is that you can actually see the bleeding as you look down the corridor. And then routine stability scans, all of which were thought to help mitigate some of this risk of rebleeding. Uh,
And
So it's the same story, and let me summarize, which I tried to do before in the big set of similarities. An acute procedure is safe. we didn't see bleeding or infection. And our rebleeding rate was between 2 and 3%. And if you think about it, if the primary disease is bleeding, then bleeding in the first week after is a possible event. And all of the trials limited the possibility of a vascular defect being the cause of bleeding. So I think the critical message is not the small signals and various safety issues, which are part of the natural history of ICH. It's that acute intervention is safe. And that's what we found, and that's what MIND found, and that's what ENRICH found.
Yeah, thanks. That's a very important perspective. How do your findings inform the debate on whether earlier evacuation, like less than 24 hours, is superior? And what practical barriers exist to achieving early intervention in real world settings? And what additional data would help resolve the different perspectives that exist on this?
What's nice about MISTIE and MIND is that both trials took in people independent of a 24-hour barrier. When we look at time in a post hoc way, and when we compare our results to Stitch, which has that time frame, and I'm very much looking forward to the MIND results, we see benefit both early and late. And the absolute percent benefit of about 50% good functional outcomes is there early and late. So the practical issue is not everybody gets to a neurosurgeon in the first 24 hours. And not everybody, particularly um, people on anticoagulants, and we now have ways to handle the DOACs as well as warfarin, should go to surgery immediately. So I think it's very important that when we gather data about time, for which we have none, that is actionable and that's a priori, we gather it in both the 0 to 24 and the later than 24, perhaps up to 48. In our analyses, the effect size remains the same at 60. And I think that's the critical data that we need. Unfortunately, minute is only going to go out to 24. I'm very impressed that in the Corcoran analysis, they looked at this question of time and all the subgroups. And there's one meta-analysis that shows a possible benefit of time. The Corcoran was written by the same Dutch people that wrote that. And when they take all data into consideration, there isn't a benefit of time. From a patient perspective, I wouldn't want 24 hours to be the limit that somebody operated on me because they had a belief that early was better. I can't imagine that early can't be good, but the question is, can you achieve the same or nearly the same result in the next 24 hours? That's my view on time.
Yeah, thank you. Jonathan?
Yeah, thank you, Dan. That I loved the way that you just framed that, and I'll have to add that so we know that based on preclinical and biomarker studies that at the cellular level we see changes then and high risk that are leading to high risk of injury and evidence of injury very early, and so therefore when we designed ENRICH, we wanted to target this earlier window. And just to peel back the curtain a little bit, it was a fascinating discussions on what that window should be. There was definitely many among our group as we were designing the trial that wanted it even much tighter than 24 hours, as that comes from our ischemic stroke literature, that obviously time is directly related to outcome. I think that we were both from a logistical standpoint and from a standpoint of the science that was guiding us at the time and presently, that we didn't feel comfortable going past that. So we asked every site to try to enroll as many patients as they could within 8 hours. But just logistically, even patients just arriving to the destination hospital within that window is difficult. With that said, what we did show is that evacuation within 24 hours was both safe and also improved outcomes for lobar ICH patients based on the primary hypothesis or based on the primary study design. Practical barriers included rapid patient identification, imaging, and surgical logistics. Just getting an operating room for some centers can be very challenging within that tight window. But what we did show was that early intervention is feasible and has real world implementation that may be limited by resource availability and workflow, however. I think that with the spreading adoption of code ICH and similar strategies, that we might be able to see more rapid identification, as well as the early involvement of surgeons, neurologists, and critical care teams to better identify these surgical candidates and be able to do this in a more time-sensitive way. With that said, Dan, we agree that we worry that maybe there's still benefit for patients further out than 24 hours. And so in our design of REACH, we have a registry where we'll continue to enroll patients that would not be necessarily enrolled in the clinical trial piece of it, but we can still begin to learn to see what is the impact of evacuation of that hematoma a little further out, because we agree it's a serious question. Go ahead, I'm sorry.
It's a good thing that you're doing that. A couple, but in ENRICH, the analysis you planned for time doesn't show an effect, and that's what you've said.
Yes. Thanks for bringing that up. Yeah. So, that we have not been able to show an effect of like this linear relationship of time that, frankly, if I would have been betting money, I would have lost a lot of money because I did believe that in my heart. But that's science is full of people that believe something in their heart, test it, and then determine it and discover it's not actually the case. With that said, I think it remains curious because of the biomarker and preclinical data that we have about the effects, the cellular effects that are happening from the moment the injury happens to evacuation.
The ischemic stroke is littered with animal biomarkers that don't hold up in the humans.
True, right?
And I'll point out that in the DISC trial in the Netherlands, where people are using emergency consent, they're not consenting the patients, they're still opening up the trial now to more than 24 hours. The second point I make is in the case series that Assam has published, we can do MISTIE in under 24 hours. And we do it, Ryan, with direct observation, not indirect like we did in the original trial. So
I think it's so interesting how this has moved the needle over time, Dan and Ryan, because like what we saw when we first started ENRICH, the idea of evacuating hematoma even within 24 hours, we received a lot of pushback that felt too acute. And that we're even having discussions like this is just, to me, as I sit here experiencing it, it's awesome. It is so fun to be able to have a conversation about hyperacute removal, but also, hey, can we actually do this further out, and how much benefit can we provide people further out? Sorry, Ryan.
Yeah, no, this is, I think, a great conversation. It's actually really interesting when you further think about the time component. We're sort of doing the opposite of what we did with the ischemic stroke, right? With the ischemic stroke early on, it was very restrictive to patients presenting early. And as we've seen benefits, we've kind of gone to allowing patients further and further out and showing that there is still benefit. Although maybe the number need to treat begins to increase, we're still finding patients that benefit from the treatment. And I think that is kind of similar to what you're arguing, Dan, is that you probably shouldn't set an arbitrary time threshold and say these patients won't provide any kind of benefit from surgical intervention. The authors from the MIND study did highlight the fact that their median time to evacuation was 10 hours more than that in the RIDGE trial. So it was 27.5 hours versus 16.8 hours. They concluded this could potentially be a reason for why there was a benefit seen in ENRICH study. But on the other hand, you also have this confounding fact that ENRICH was able to sort of isolate out the lobar hemorrhages and find a signal there of benefit. So I think at this stage, I don't personally really have a great answer as far as is time ultra important. To me, it intuitively makes sense that addressing the pathology earlier likely has benefits. And I think we've got the technology and techniques now to mitigate against any active bleeding during procedures. And I think there's a good argument that it actually may be better to take patients that have an active bleed so that you get to them before the hematoma continues to expand and causes more damage if you were going to wait until they had a stable bleed. There are a lot of other pathologies in neurosurgery where time is shown to be critical for a good surgical outcome, whether it's an epidural hematoma evacuation, subdural hematoma evacuation, certain spinal pathologies. So we know in general with any kind of neurologic injury that the sooner you can address it, the better for recovery. Um, I don't think we're right now anywhere as aggressive with the urgency that we've seen with ischemic stroke. We've got incredible systems in place. And as you pointing out, Jonathan, that this code ICA should hopefully help kind of bring the hemorrhagic stroke into the same level of care that's seen for ischemic stroke. And as this occurs, I think this will enable facilities or hospitals and the ORs to begin to have the appropriate resources to manage these patients so that you can get them urgently to the OR if there is signal that they should be done much earlier as opposed to waiting. So I think there's a fair amount of organizational change that is very possible because we've done it with large vessel occlusions. And this process improvement should hopefully improve patient outcomes.
Yeah, Ryan, and continue with kind of the ischemic stroke analogy that you're talking about. From a system standpoint, we also see that that there's nothing really magical about time. It's more what happens to the biology over that time, right? And that's what we're actually worried about, and how do we interfere with that progression? And so what we're trying to find is what is the optimal period at which that biology is still allows us to have an impact when we intervene. And it's a fascinating time and a fascinating question.
Yeah, thank
You guys, one of the benefits of being old is the same question comes up multiple times. There aren't any other benefits to being old, I can tell you. Um, um, I was told in the 1990s when I started my work that everybody knew that deterioration in ICH occurred because there's perihematomal ischemia in animals. And there were some good models that showed that. I did my own, and we didn't with the best available technique, microspheres. And there's perihematomal oligemia. I think we've learned this in ischemic stroke. You need to deal with humans in the end. Theory's great, but deal with humans. And we want to optimize the result for humans, not animals.
Yeah, thank you. That's a great perspective. So switching gears a little bit, it sounds like achieving a high degree of clot removal is the goal, but how much is enough? Let's talk about the extent of evacuation and the correlation with functional outcomes and mortality with achieving that target of less than 15 ml residual volume or 70 to 80% volume reduction. And does the location of the hemorrhage, like lobar versus deep, change how much clot you need to remove to see benefit?
Well, yeah, and that's, the great contribution of ENRICH is to say that lobar behaves differently. I can be quick. Less than 30 was the threshold for preventing mortality. So getting rid of a mass effect of 30 cc's and reducing it. And in our data, I mentioned it before, 28 is a threshold for functional improvement in lobar, and 9 to 12 for deep. Jonathan?
Yeah, thanks, Dan. I'll also be quick. I think that this is perhaps the paramount issue, though it is not the only issue. Otherwise, I think we would have seen different outcomes echoed in other trials. But what we showed in ENRICH was that functional benefit did appear to be correlated with the degree of residual volume in particular. And it was obviously more pronounced in the lobar ICHs compared to the deeper hemorrhages. In post-hoc subgroup analysis that we're working on publications for right now, that we see that location dictates the definition of optimal evacuation to optimize the clinical outcome. In the deep hemorrhages, these may require end-of treatment volumes or residual volumes of about 6 mLs, while lobar hemorrhages have a higher tolerance, which may be the most unsurprising but interesting finding that I've ever been a part of. And we see that they can tolerate that 15 to 20 cc's. in the end, we see that these locations as a dividing feature for surgical targets.
Ryan?
Yeah, if you look at the MIND data, 80% of deep hematomas and 75% of the lobar hematomas achieve this goal. So I think they demonstrated that this technique is applicable to both locations. Like other studies, we often try to quantize outcomes and try to find thresholds or cutoffs that are easy to apply at a patient population to determine who should or should not get treated. We saw similar stuff with GBM, where there's a paper that came out from UCSF early on that showed a kind of arbitrary number that 78% of GBM resection resulted in a good outcome. And since then, there's been additional literature that shows there's stepwise improvements with greater tumor resection. I think there's probably something similar to be said to hematoma evacuation, where our current threshold is probably one that we see some signal, but getting more clot out is probably even more beneficial. The thing that's challenging, though, is that you're often operating in deep structures or eloquent parts of the brain for some of these hematomas, where you have to balance the desire to have this kind of perfect looking post-operative image with no clot versus potentially having collateral damage to surrounding tissue, whether it's aspirating white matter or getting into some sort of eloquent region. And I think as we get further along and we continue to study this, we'll probably get better guidance as far as what should be the target goal. Doesn't matter if it's a low bar to be a certain threshold. If it's a deep hematoma, does it have to be a different threshold? So I think these are all things to be determined.
I have one question for Ryan, and that's the interesting thing that suggests to me this heterogeneity of response, and that we haven't proven who the population is we need to operate on and when. Is Ryan's mind did the best on removal. The median clot size is 6 ml, so half of the patients were 6 ml, and yet the point estimates of benefit in hypothesis generating are very small in mind. And I'm interested in what your thoughts are. Mine are that we technique, besides location and time, is the other thing we need to understand better. But I'd be interested in what you think. You're the only neurosurgeon here.
Yeah, I don't think I have a great answer. I, I do wonder to a degree, is it teasing apart some of the nuances of, is it time? Is there something else to the technique that is occurring that we're really not appreciative of? I mean, I think ultimately there probably will be some sort of head-to-head study of different techniques down the road, but I don't think I really have a great answer.
Yeah, all great thoughts. So this brings us to the big picture question for our clinicians listening. Given all this data, how do we synthesize it? Is there an ideal clinical scenario for one of these techniques over another? Or can we be technique agnostic as long as we achieve safe and maximal clot evacuation? Ryan, let's start with you.
Well, ultimately, I do believe there's a role for ICH evacuation. I think if you survey different surgeons, you'll get sort of different perspectives, even to this day. But if you look at the evidence for lobar hemorrhages, I think it's pretty clear that patients benefit from this procedure, and it's something that we should be offering patients. The secondary discussion, though, really follows with, does the family or the patient have an understanding of what the outcome is going to be? And I think with a lot of surgical procedures we perform, we need to make sure that patients have a good understanding, especially when you have major neurologic deficits, that this may not by any means reverse what they come in with. And you have to really set expectations when you're going to offer a patient a procedure. But I think it's very reasonable to offer surgery for these patients and let them know that we have evidence that this is beneficial. Whether you choose an endoscopic approach versus a more port-based MIPS approach, I don't think matters a whole lot for the lobar subgroup. And more than likely, surgeons will probably be choosing a technique that they're most comfortable with, and it allows them to ultimately achieve the desired volume of hematoma reduction. Applying these techniques to deep hemorrhages with an expectation of improving functional outcomes at 90 days is obviously a little bit more challenging, as that data sort of remains to be, I think, elucidated or really conclusively stated. So for deep hemorrhages, to me, it makes more sense intuitively to do an endoscopic approach because you are, I think, more likely to cause collateral damage when you use a port-based approach. It's a larger device. Having done both, I feel like you're more likely to sort of go off and get into tissue where you're more confined with an endoscopic device. But again, this really relies on what the operator is comfortable with. Either way, I have a bias or preference to evacuate hematomas because I think if you're going to try to keep a patient alive with a deep hemorrhage, removing the hematoma through a smaller incision through either of those minimally invasive approaches is to me superior than doing an open craniotomy where you really expose a lot of the cortex or simply doing a deep decompressive craniectomy. Those procedures carry significant more morbidity due to wound healing issues, particularly those that require cranioplasty down the road. So I do think that if you have a patient where you know that they will otherwise most certainly die from the mass effect from hematoma, trying to evacuate the clot instead of doing a craniectomy is preferred in my opinion.
Ryan, thank you. I definitely agree with you that there's a role for ICH evacuation using some, I think, minimally invasive procedure. I do wonder sometimes, especially since we're all academics here, if we get caught up with an emphasis on the wrong syllable sometimes. And I wonder if technique is important as we sometimes get caught up in our common conversations. I think that really the principles, whether you're doing a MISTIE approach or the mind approach or the ENRICH approach, is that you want to preserve tissue as much as possible. And we know that with the ENRICH approach and with the MISTIE and the mind approach is that from imaging studies that are related to them is that white matter tracts can remain intact and are less likely to be destroyed with those approaches. Um, and I think that with that as our goal, I think that as a non-surgeon, I think giving surgeons options to figure out what they're expert in and what they're comfortable with is really powerful. And something that I would love to see us see as a path forward. And I think that, with the REACH registry that I've talked about, we're letting surgeons and allowing surgeons that are outside of the clinical trial to pick their approach that they prefer, and continuing to kind of learn from that and hopefully can provide some data on that question. We do know, though, that with the MIPS approach that we have safe clot evacuation, and that seems to be with preservation of tissue, a really key component to good outcomes. And we have data to say that we can remove that tissue and have better outcomes than medical management, at least in low bar ICHs. And that otherwise the technique selection, I'm of the opinion that this should be guided by patient anatomy, center expertise, and the ability to achieve a substantial evacuation, perhaps even as early as possible. For these deeper hemorrhages, I think that we have a lot more questions, and that's why all of us are continuing to be involved in this space as clinical trials to try to help guide us and move this forward. And I would close with this: is that just the level of excitement that I have about what we're seeing in terms of the dialogue about this disease process, that even as early as recently as my training, where it was so much nihilism around it, and now it feels like there's some hope, and we really are beginning to, I think, help people, which is why we all do this, have better outcomes than what they would have had without this. And so that's a really exciting place to be in. I'm really looking forward to seeing what we can learn over the next several years by as we're continuing to ask questions about this. Dan?
I agree. I think it's clear when you look at the three stories that each one says there's substantive reason to have hope. I think we need data, Parita. Um, I'm the only person here who's done a study that's compared the two techniques, endoscopic and MISTIE, which is the most gentle and uses the smallest intrusion. And I want to emphasize that. Um, our results were that an endoscope was the same, but a very small number of patients. So I think we need real data here. I expressed the concern that Just like there's a priori positive signal in ENRICH, there was an a priori negative signal that ENRICH stopped enriching with the DEEP. And we're going to get more about that as Jonathan and Gustavo publish. But patients did less well in the surgical group um, as a point estimate in ENRICH. So that's for me a warning, and I'm glad that we're going to study this again. I think what we correlate the surgical task with is really important, and Ryan brought this point up. I think we need to correlate it with an outcome that patients understand, not that doctors understand or perhaps is more statistically efficient. And that's why I like the percent achieving the Rankin 0 to 3 level. I think the utility weighted Rankin is great, but explaining what it means to a patient is a big problem. And what we need is the correlation between technique and the task that's achieved by the technique, the removal, and the outcome. And that's why I think we need more data here.
Yep. Yeah, this has been an incredibly clarifying discussion. For our final question, let's look to the future. The AHA and ASA guidelines are the benchmark of our practice, you could say. And in the light of these trial results, how should we interpret the current guidelines, and what specific changes do you believe are warranted in the next update? Dan, let's start with you.
Sure. Well, I just echoed what Jonathan said. MIS is extremely promising. I think the guidelines are going to say we need more data, which we've described, and we need several bigger trials in order to know that this approach works for a predictable percent of patients and produces a predictable benefit that a patient and their family can understand before they agree to undergo the surgery.
Jonathan?
Yeah. The current guidelines recognize that minimally invasive evacuation may improve outcomes for select patients with lobar hemorrhages, especially when performed early in substantial clot reduction. And we saw that through ENRICH, which is a phase 3 randomized trial that I think provides high level evidence supporting this approach. And I suspect that future guidelines will continue down this pathway of interpreting the data and saying, yep, and giving us more and more promise towards minimally invasive. And I do believe ultimately in my heart of hearts that we'll see something at some point. But I think this next guidelines is going to be more stepwise in its progression. But I think that, in talking to surgeons and centers across the country, there is, I think, excitement about it. And also, I think that there is a significant uptick in the removal of the lobar ICHs in particular, based on the ENRICH data.
Anything you'd like to add, Ryan?
I think from a surgeon's perspective, you can approach a patient or the family and offer surgery for a lobar hemorrhage and tell them we've got good data that supports that this is the best way to improve your chance of having a good outcome. I think that's a very critical thing for us to be able to communicate to the person you're doing the surgery on or to their family. I think most certainly you'll probably see future studies that evaluate these techniques head to head. Anytime you've got very surgical approaches, there's almost always some sort of direct head-to-head study or at least a meta-analysis to start to try to elucidate which procedure might be best. And I think that is important to determine going forward. There's additional things coming online like active irrigation catheters that could also sort of augment a MISTIE type approach as well. So I think as we improve our tools and our techniques from a surgery side, it'll be interesting to see how the outcomes change with future studies. And I think, people really should pay attention to this area and keep in mind that it's still, I think, very early on in this story.
Great. Thank you, Dan, Jonathan, and Ryan, for sharing your expertise and insights with us today. This has been a great discussion regarding the rapidly evolving landscape of ICH treatment. I'm going to try to summarize the most important points from our talk today. it's clear that we're moving beyond the era of wait and see management for many of these patients, and minimally invasive approaches, whether through aspiration or port-based techniques, have demonstrated promising results, particularly in lobar hemorrhages, and perhaps highlighting the importance of timely intervention. For patients with deep hemorrhages, the benefits seem to be less clear, but we're learning to become better about patient selection. And ultimately, it seems like safe and maximal clot reduction seems to be the key. And so, what are some of the key takeaways? First of all, I think we would all agree that we have good data about the effectiveness of these minimally invasive options. And second, I think we agree that the goal is safe and thorough or maximal clot evacuation. Lastly, the critical factors are going to be patient selection and discussion with patients and families, as we said, and sorting out the timing factor and making sure that surgeons' skill and experience is great with their chosen approach. And we'll continue to refine our techniques, analyze the data, and tailor our approach to the individual patient and their needs. This has been a great discussion. Thank you for joining us today to learn more about ICH. Thank you all for participating in this Heartbeats from Lifelong Learning with me today. To get additional information, please visit learn.heart.org. Thank you.
Thank you.
Thank you.
Yeah, that was great.